when I woke up, very confused. She said, "You almost died last night. In fact, no one can believe you were alive."
I went into the games not knowing what was coming.
As humans, we just hate uncertainty.
You just sensed that it was out there.
You have to start somewhere.
We're all programmed to push ourselves even farther.
This is On the X, an IRONCLAD original. Welcome to On the X. My guest today is Dr. Ross Zafonte, a world-renowned expert in traumatic brain injury and rehabilitation medicine. As the lead author of Brain Injury Medicine, Principles and Practice, with over 300 peer-reviewed publications, Dr. Zafonte has shaped how we understand and treat brain and spinal cord injuries. His groundbreaking research has also earned him accolades like the Admiral Charles Lemoyne Distinguished Healthcare Professional Award. So here we go with Dr. Ross Zafonte on the X. Now, are you in Missouri now? Is that right?
I am. I'm still with home base. I'm their national medical director, but I am the executive vice dean at the University of Missouri. I'm professor emeritus at Harvard. And I came here and helping to be near where my wife is from. And after I was here like almost 30 years ago, I hate to say it.
Got it. Okay. Are you doing brain health stuff there?
Still, absolutely.
Okay.
That's what I will be doing all day tomorrow.
Got it. So what does that look like on a day-to-day basis for you? Are you doing research? Are you doing lecturing?
Yeah, so I'm doing management with all of the chairs of all the departments.
Okay.
Focusing in on administrative tasks and performance, trying to grow the research and clinical missions across the health system and the School of Medicine. Focusing in on a bit of my own research still, a fair amount of it, seeing a few patients, and then trying to mentor some of our young folks so they can perhaps take on the mantle as I age out in time.
Got it. You mentioned home base, and I'm going to say that most people listening to this probably don't know what that is. So can you talk about what home base is?
To me, home base is a miraculous place. So founded some years ago to really address the invisible wounds of war. It is a not-for-profit affiliated with Mass General Hospital, Mass General Brigham, that is this incredible dedication to veterans and service members and active duty members. We started it, all those years ago in a single room. And it's really focused on clinical care, wellness, education, and research to give back to our service members in one matter or another. Everything from our special forces members to people who had a single tour in Iraq or Afghanistan. It began in 2007 after the World Series. The Red Sox players and their owners met with wounded warriors at Walter Reed. And a Red Sox chairman, who's just terrific, Tom Werner, made a commitment following this, I think it was 4 or 5 hour visit, to partner with Mass General to address these signature invisible wounds of war. And what we grew it through from this little operation to something that's really a national operation. Since its inception, it's really stunning to me. It served, I think, 26,000 veterans and family members with care and support, 80,000 online or in-person training sessions, and really adapted its model to providing evidence-based care, to innovating, and being very much, in my mind, a gold standard for veteran and warrior care.
And what exactly is going on there? And I say that being, I'm somebody who's been to home base, so I know the kind of the answer here, but just kind of painting the picture of what people go through there.
I think the special sauce of the place is personalization, Chris. It's really delving down deep and understanding what one person needs versus the other. And really thinking of the fact, especially for our special forces members, that a lot of what they experience isn't one thing, it's a multitude of things. In some ways, they are a Gordian knot and we are trying to be Alexander the Great and cut it out. Well, sometimes we have to pull it apart. For example, people may have or often do have traumatic brain injury or repetitive injury, but frankly, they may also have a lot of pain. Warriors do incredible things and have joint problems and hip issues, back and neck and shoulder. They may have sleep apnea, and they certainly very much might have a number of other issues such as PTSD or depression, just dealing with all of this stress. And so all of these things and others go together to make a little bit of a toxic potion that even they are often troubled to pull apart. And all our job is try to look at each domain area, see what can be treated, and really set people on a path to an enhanced health span. So I often talk, Chris, about lifespan and health span. And to me, it's important to live a long life. Sure, I'm getting older. But what's really important is health span, that time that you're not really burdened with the extent of disease, or if you have it, you can overcome it and you can push forward and you can go to your child's event or your spouse's desire to go somewhere, or you can live your life to the fullest. We've come up with some of our colleagues from the Football Players Association and others at Mass General, this concept also of joy span. And that you do you in some ways. And that ability to, no matter what you have, mitigate it enough to where you live the quality of your life doing you is really the important thing.
Yeah. And we have a partnership with Homebase at the foundation. So we fund guys, NSW. That's how I went, right? NSF funded that. But there's sort of there's a diagnostic thing. If I recall correctly, I spent like a multitude of days sort of getting various tests, diagnostic stuff. I did a sleep study. I did all these cognitive tests. They did an MRI, obviously. And then there's sort of, you're given any diagnostics from that, diagnosis or results or whatever. And then there's certain, there's cohorts, right? There's sort of like I don't know if it's inpatient stuff, but there's programs that guys can go through too, right?
100%. So the diagnostic part is important, right? Because we pick up a lot of warriors are warriors. They're incredible people, but we pick up a lot of things. They're not always self-admittedly often the most transparent.
Mm-hmm.
But we pick up a lot of people with sleep apnea, secondary pain issues, mild cognitive disturbance or depression, various MRI of the brain-related issues, and then we make a plan. And that plan leads to people being in specific cohorts. They may be in a cohort of a lot of cognitive therapy. There may be in a cohort of things where we're treating multidisciplinary kinds of issues, whether that's PTSD, whether that's pain, whether that's co-occurring substance use. All of it is part of our family of issues.
Mm-hmm.
And I think there's an important element, Chris, of people going through this with others like them.
Sure. Oh, of course.
When you feel I'm alone, I'm the only one with something, that's a hard place to be. When you know others can help you get through, that there is an evidence-based plan to get you back to the fight or get you back to your family, there's a return on investment there that's worth the time. And when brothers help you pull you through, it's very meaningful.
Yeah, of course. By the way, why the Red Sox? What was the Red Sox interest in this? I'm from Boston, by the way. So this is like.
So you're one of mine.
This is near and dear to me. Yes. Yeah.
Hey, we might have a good year this year. I'm hoping.
Okay. Yeah.
The Red Sox have always been, of course, I'm not even there on full-time basis now. But you're getting my opinion, the most marvelous organization via the Red Sox Foundation in thinking about, from an athletics perspective, how do they contribute to the community? How do they do a greater common good and use their foundation and that lever arm that is Fenway and Red Sox brand. I mean, it's universal in New England and beyond to create a good. And Mr. Werner himself was passionate about veterans, given his own, I believe, his family situation. And other members of the ownership also had family members who had been part of service. And so they thought it important to visit Walter Reed, which touched, I think, a string in their heart, that this was an area to put a lot of emphasis on. Because, so few people serve. And certainly when we think about the program we developed for our Special Forces members, so really few people have extensive exposure that I think those of us who are impassioned about this and those such as the team that have the means to echo their voice, I think owe the community and those folks who've done that remarkable work a better path forward.
Mm-hmm. Now, what got you interested in it? You've been doing this for a long time, and
Since the founding.
Yeah, but I mean, even beyond that, just in terms of outside of home base, just kind of brain health, and specifically brain health, because that's kind of your area of expertise. And I've talked to other people on here about the other aspects of things that affect veterans, special operations veterans, but I really want to dive into kind of brain health with you. So what got you interested in that in the first place?
So I was a trainee resident, and I was asked to work with one of my mentors on a particular patient case. And I became fascinated that there just weren't enough answers. I looked up everything. I went in the old days to the library. I scoured around, and there weren't good answers to what happens to people after brain trauma.
Mm-hmm.
And so I became sort of fascinated and had the opportunity to spend time with some real experts around both the United States and the world, and got on a little bit of a mission there. And my mentor said, well, why don't you really focus in on this area? Because there aren't a lot of people at the time really putting a lot of emphasis on it. And, go spend some time with people and then think about doing some research in this area. And so I took an exit path from what I was going to do into this. And I'm very, very glad I did, because, it's the fulfillment of seeing families note people recover of an area with constant discovery, and the opportunity to help everybody from athletes to veterans.
And did you start off with athletes? I mean, because TBI is one of those things where, for me anyways, I feel like we first heard about it with football players, CTE, NFL, impact. And then it became something that was also associated with special operations, maybe the military in general. That wasn't the case for you?
Yeah, so I started off at the very beginning of the field with those people with the most severe of injuries.
Okay.
Very severe patients, but also had an interest from speaking with some mentors and others that individuals were exposed to repetitive head injury, whether that's athletes or the military. We picked up on the military issue fairly early on, as well as the athletic issues. That can't be good for you. And this idea that people just get better in 5 days and they're good and it's nothing, that never made much sense to me, especially when we were talking about people who had had a lot of exposure, not a single exposure. And so we began doing work that went from the lab to the clinic to ask some of these questions in those groups of people. What happens to people over time? What happens to the animal models? What are the key factors involved in that? Why do some people do well and other people not so well? What happens to people in their middle life, as we're studying both in football and in our special forces and military population? Are they experiencing, in some ways, an early middle life, or a robbery of a piece of that middle life? And so we began to put pieces of this story together over 25 years or so.
Okay. When did we first learn that I mean, sort of like you say there, I want to think that intuitively you sort of think, let's talk about football as the most sort of impactful head, blunt force trauma, right? Impact. Intuitively you kind of think, yeah, that's probably not the best thing in the world, but forever that just was part of the game and no one kind of, I don't think, considered it. In fact, I think that it used to be like taught, yes, tackle, lead with your head, all of that. So at what point did it come on the scene that this is actually causing legitimate damage that can result in this condition? When did that come into play?
Well, let me take a little step back because I think you're spot on. I think we had a long history of knowing this can't possibly be good and ignoring it. That's the truth.
Yeah.
And we ignored it because people in the proximal period of time while they were playing would just blow it up.
Yeah, right.
But what we didn't understand is the longitudinality of some of that. So there was a report when I was back in Pittsburgh by Bennett Amalu, who was a pathologist who worked with Steve Tukosky, who was one of my mentors, who was chair of neurology at the time at the University of Pittsburgh, where, they reported on Mike Webster, very public, who was the center for the Pittsburgh Steelers and noted some unusual pathology in his brain that didn't make sense with the patterning that had been known in Alzheimer's disease or other things.
When you say pathology, was it the behaviors from him, or was this like looking
I want to separate that out, Chris.
Okay.
That's brilliant. Let me separate those two out.
Okay.
Because it's critical to the discussion. The left-hand side is changes in the brain cells.
Okay.
Or the morphology of the brain, right?
Mm-hmm.
So in other words, my highway has some challenges within it. It may be partially clogged. I may have missed problematic exits, etc. That's different than what we refer to in some ways as the phenotype, which is how the person actually is. Right. There can be people with clogged highways or even highways where there aren't a lot of cars on them and their traffic is pretty good. And there are other scenarios where that's not so good.
Right.
That direct linkage, we're still fighting to understand
that's
what
good to
this
know.
means to that.
Yep.
Because there are people who we see who've either had remarkable careers in the military for long exposure as special forces members, or those who have played professional football or other contact sports who are clinically just fine and they're in their 70s.
Yeah, yeah.
And there are others who are fairly young who are not, and they are very real.
And I just think that that's such an important point, especially coming from you, because I don't know your experience here, but I feel like sometimes the messaging, maybe not explicitly, but it sort of just feels this way, that it's like, okay, now military veterans, especially special operations, equals TBI equals death sentence, or equals like, you're going to have some kind of cognitive decline. And to your point, I don't know that that's necessarily true.
No, it's not linear, or we don't know, especially in veterans, how that relates. Perhaps a little bit more advanced in athletes, but not in veterans. And we're not secure that blast-related trauma has the same type of pathology as athletes. In fact, those cellular changes may well be different in some work by Dr. Pearl, Dr. Edlow, and others.
Right.
So I am not convinced that it's the same pathology. We don't know how it leads to behavior, right? I don't care if I have a bad family history as an analogy, Chris, heart history.
Oh, okay.
Let's use that as just an analogy.
Yeah. Well, so do I, for that matter. So,
right.
So you're in good company.
Good company if I'm with you.
Yes.
And the chances of me having right coronary artery calcium are probably pretty high. But I'm a good camper. I stop running at 5 miles, 6 miles because I'm bored, not because I can't. I don't eat badly. I have no symptoms. Do I have a cardiac syndrome? Probably not.
Right.
I have a risk factor And so among the things to understand are people with exposure. How do we help them mitigate risk?
Yes.
Things like avoiding sleep apnea, being very aerobically active, making sure that we control their pain, avoiding being depressant, making sure that we don't have issues with GI or other related, I'm sorry, not necessarily GI, but other pathology
Yeah.
that can cause co-inflammation for people. So I think we want to take a holistic approach to mitigating their longer term problems.
Yeah. So just sticking on the athlete thing, because I do want to distinguish this from the issue that a lot of veterans get and how that comes about. But like on the athlete, so like on something like CTE, what causes injury, brain injury, to become CTE? And then at that point, is it that point degenerative and it's like, hey, it's only a matter of time here?
No. I think what we don't know is the stage. There's a particular type of pathology that is in the perivascular areas of the depths of sulci that converts a protein called tau
Yep.
that is associated with CTE. Now, mind you, that's not so clear in blast exposure, where it may be completely different or somewhat different in astroglial scarring.
Yep.
Pathology. Again, not necessarily always linked to the behavior and the phenotype of the person, right? How much that contributes, we don't know.
Okay. Got it. But that diagnosis, the tau, so to speak, is that something that you're able, how do you diagnose that? Do you see that on MRIs? That's something?
No, they can't see it yet on MRIs. So CTE itself, right now, is a postmortem diagnosis.
Oh, really? I thought that CTE could be
cannot diagnose it yet in life.
Okay.
There are attempts to do it in a lot of different ways, but it is a post-mortem diagnosis.
And it's a specific, this tau it's a protein? Is it appears in the brain?
We all make it, but it's in an aberrant format.
Okay.
And localization that we believe is resulting in neuronal cell death.
Okay. So let's put this one again before we get to the sort of veteran special operations guys. I want to put this in terms of parents and kids sports, because that's something that regular people care about. At this point, how dangerous is this stuff? Because like football for kids or even other sports. I mean, look, my son had a concussion this past soccer season, clocked heads with a guy out on the field, went off the field. The trainer gave him the kind of the test, whatever they do. And it was like, yeah, you have a concussion. And then he had to do a very specific protocol where he couldn't do X for a certain number of days. And then and it took like a week before he was basically allowed to do that again. So like, at what point is there a risk for kids, in that? Is it just come down to like, hey,
we don't know.
Okay.
We don't know. But here's what I would say. Much of this may be related to exposure. Mm-hmm. I'm not a big believer. My own son played hockey for a long time and in college and beyond. That young people should be involved in hitting and ultra contact. Not because there's a direct linkage strongly in the literature with long-term outcome, because we don't know.
Mm-hmm.
Because their heads are like bobbins, because their weight and other disproportionate, because there are skill-related issues. That's number one. Number two is we do need to consider the fact that many of the examples that we're drawing from in the pathology are extreme exposures. For example, in football, these marvelous gentlemen are so good that they barely came off the field in high school. They played offense. They almost universally, or many of them, also played defense, specialty. No rational coach in the 80s and 90s and early 2000s would have pulled them off the field. They're the warranty to victory because they were so far standing out, right? That's different than Sam or Bobby, who I played a few snaps on.
Right.
at wide receiver, and then I played a few things here, and my total exposure was about. So I think it's the number of hits, it's the exposure, it's the force, and it's the duration. And a lot of this is peak acceleratory forces and the duration of that kind of exposure, much of which is extremic in that group of people. So it's believed that it's very likely that you need about at least 5 years of exposure. It's possible less, and then the leveling within that exposure is unclear. So you doing a few games as a junior and a senior and a sophomore, I don't know that that's the same as these guys who were never off the field in high school, 4 years of college, 8 years of the professionals.
Right. Okay.
Because when we measured the G forces in some of those people, they're astronomical.
Right. Yeah. And that makes a lot of sense. I think that's important to frame up, because I feel like people get sort of like hysterical about this these days and can be really I'm not saying we shouldn't protect. Of course we should, but I just feel like when it potentially takes away from like, hey, there's a lot of upside to athletics, right? Not from physical fitness, the camaraderie. I mean, like there's so much good stuff about it. And
it's totally good. The other thing is you learn to work with others on a goal.
Yes, of
There have
course.
been a couple of studies that have looked at this and said kids who play team sports of any kind in high school or college wind up being more successful because they are collaborators on goals.
Sure. Yeah.
Right? There's a fitness element that you raised. I think the thing to do is there needless exposure that doesn't improve one's learning of the sport?
Mm-hmm.
Let me give you a couple of examples.
Okay.
One of which is those of us who played high school football all remember Oklahoma drills, right? Just butting heads with people.
Okay. I was not a football player, so
it didn't teach you a true football principle, right? And so there was nothing to learn there. It was needless exposure for no benefit.
Got it.
Younger kids checking in hockey. Well, they can barely skate. So let's get them to be good skaters and learn the game and learn the positioning before we have them checking needlessly, right? And so all of those kinds of things probably are needless exposures. I don't personally believe that there's any benefit to some of those at a very early age.
Okay.
The elite people, the few folks who are ultra elite, and there aren't that many of them, who are going to go on if they start doing that at 15.
Yeah. On the X is proudly presented by Mechanix Wear, the gloves trusted by pros. Originally designed by a legendary race mechanic, Mechanix Wear has become the top choice for anyone who needs tough, reliable protection. From construction sites to the front lines, these gloves offer unbeatable comfort, durability, and grip. Stay cool, dry, and in control with Mechanix Wear. Gear up for whatever comes your way. And just speaking personally, Mechanix gloves were the go-to glove for us in the military, certainly. And they're still my go-to glove when it comes to just working around the house. A glove that I've worn for decades at this point, and is still kind of my go-to glove. Mechanix Wear gloves are available at most retailers, as well as on Mechanix.com and on GSA Advantage. Mechanix Wear is also proud to offer an exclusive 15% off discount through the ID.me program to military, veterans, and first responders. Click on the ID.me button in your shopping cart and follow the steps to verify your eligibility. What about just the last kind of thing here on this subject specific? What about heading a soccer ball? Because that's the one I hear. There's people who like, look, this was my sport. I grew up playing soccer, my main sport. I coached it. And look, we headed the soccer ball from as early as I could remember it. I was a defender. I used to have to head the punt coming off of the the goalie's foot. And now it is like there's rules where the younger kids can't do that at all. And I just wonder about the risk there, because I will say the downside I see as a coach is they get to be in their teens, like going to high school, and they don't even know how to head a soccer ball, which is kind of like an important skill if you want to be good at the sport. And I'm sure this has happened out there, but given the prevalence of soccer, that kind of football across the world, I just don't ever hear about brain injuries, like, on a massive level, like CTE, that kind of thing with professionals.
Well, there's a really cool paper from Willie Stewart's group in Scotland. And they looked at soccer players in the north of Scotland, and they did find a higher neurodegenerative disease death.
Okay.
And this has been reported by a number of different groups. They also found other neurodegenerative diseases that are higher, dementia, other things.
That's good. That's because those guys are drinking scotch all day long, though.
Maybe. The issue may well be, again, level of exposure and when people are trained. So, just like in hockey, where they now have kids often go into checking camps, learning to check properly, you could envision a scenario in soccer where people adapt that skill and get it up quickly as they're slightly older. The other thing is to think about the fact that that ball on a mass basis versus a kid's head, when you're thinking about someone who's now a teenager, it's not the same proportionality.
Sure.
There are mass differences and acceleratory differences that probably play a role. There is some work by a number of different groups that say there's sort of a risk in the number of total header exposures. And this is, of course, still very preliminary, but there are those who believe that maybe 1,000 headers a season, whether that's in practice or other.
That's a lot.
That's a lot, is likely a breakpoint threshold for various types of neuroimaging related changes. So we did a study a long time ago with Inga Korte, who's in Germany, but was also at the Brigham and Women's Hospital. And we looked at kids in the Bundesliga Development League in Germany. So in Germany, of course, you go into these development programs, whether that's with Dortmund or whoever. And then we compared them to swimmers. And we looked for change throughout a season in a particular neuroimaging paradigm. And it's clear that the soccer kids had a different profile.
Okay.
From the beginning to the end of the season. Now, those were kids who were, my desire in life is to be a pro.
Right.
We're doing extensive exposure early on. So the issue is, how do we teach the fundamentals of the sport and then mitigate the unnecessary?
Yeah. So let's actually, that is the last point then on this. And then I want to shift over to kind of like the, blast TBI and all of that stuff. But on this point, outside of what's already been done, are there other mitigation measures that could be put in place, right? So like the obvious helmets for sports where it's appropriate, to your point, like not doing things that are unnecessary or don't teach any type of skill. Outside of that, and then the protocols, if somebody does get a concussion, are there any other things that we should be thinking about? Like supplements, I don't know, or, there's like that Q collar thing now that's out. Like, what about that?
Okay. So let's think about that. So we have unnecessary exposure. There is some data about neck strengthening. So having a stronger neck to resist torsional forces might be a preventatory.
Okay.
Being adequately hydrated.
Sure.
Is probably critically warranted. Not being necessarily hyperthermic or being in an environment where your body temperature is super high is worrisome. The Q collars got approved to be used in ice hockey. The data in many people's eyes is as yet unclear to their benefit. The principle is that by compressing here, you actually wind up with more blood volume here in the brain and prevent some elements of the movement and slosh.
Right. Yep.
There are some rather deep faith beliefs there about that. There isn't any data that I know of about that in blast for sure.
Okay.
Whether it's effective in ice hockey, soccer, and football is a point of some debate among different people.
Okay, fair enough. So let's shift over to kind of the blast stuff. So my first question here is, when I look at those like broad brush two categories of people that have potential risk for brain injury, got the athlete side, which is by and large impact that kind of trauma. Pretty obvious too. And I want to say, not entirely obviously, but kind of soul sourced in the sense that you look at very high level athletes like in the NFL, everything else they're doing with their bodies is like race car stuff, right? Like super dialed in nutrition and sleep and exercise, right? Like, so everything else is like just optimizing their athleticism and their physical health. And then they've got this potential risk. Special operators, conversely, there are multi factors that go into potential degradation here, right? And then you put on top of that things like crappy sleep, crappy circadian rhythm, probably not the best nutrition when you're overseas, all of those things, right? And so the question that I want to start with here is, how do we know that it's the blasts that's causing this, or is it only blast that's causing it? And actually, sorry, I should back up. Explain the difference too, like between, you talked about it before, like the CTE type tau damage, and then like interface astroglial scarring, like what that is exactly, right?
Right. So it is, a different cell type that is involved, and it's been proposed to be much more signature for blast-related exposure. And I think that your point about warriors is fair. But there are a lot of, to my Gordian knot example early on, a lot of things to pull away there.
Mm-hmm.
You do have poor sleep. You also have people parachuting.
Yes, right.
You have people doing underwater work sometimes with some elements of barotrauma exposure. You have guys who are doing extraordinary things and frankly have a lot of secondary pain or injuries. That pain is believed to not only be a joint problem, but can also be a neuroinflammatory here in the brain.
Toxic exposure.
Toxin exposure is not a small thing. It's a classical question I would always ask. Tell me about this, that, the other thing, and I get a lot of positives. And so, yes, repeatedly being exposed to blast is not a good thing. But I would also argue that all of these other things can't possibly make your brain more resilient. It probably has to make it less resilient.
Mm-hmm.
We're taking the most elite of people, and in some ways, we're hitting them, and moving them back this way.
So, but just going back to the interface astroglial scarring, and this is, to your point, it's a different kind of injury, right? Basically, it's in the interface there. It's like in this sort of liminal space, pockets there in your brain, right?
Yeah.
How do we know that it's caused by blast, though? How is that? What studies have been done to ascertain that that's what's causing the injury?
These are postmortem studies.
Okay.
These are postmortem studies like the others. So do we know that it's no other cofactor could be producing that? Probably not.
Okay.
Do we know that we have people with high levels of exposure who, unlike others in the field, have that change?
Mm-hmm.
Yes.
Okay. Got it. Yeah. I just think
but the numbers are small, Chris.
Mm-hmm.
We're not dealing with the fact that they've done 1,000 people and seen that.
Yeah. Okay.
We're dealing with relatively small numbers.
Yeah. I'm just thinking, you mentioned like parachute openings. I mean, that's another place where your brain could definitely get rocked around in there, right? Or I spent a lot of time in boats that went really fast and hit 10-foot waves over and over again for like hours at a time, where your head is just going like, that,
I mean,
right?
those are our swing. Then they're going like this, right?
Yes.
So that is another thing that we're unclear whether that produce what is the distinct soul type of pathology, or is it, a polyproteinopathy, a polypathology of multiple different things. I mean, it's really known as gliosis, right? And it's a type of glial cell in the brain that proliferates and forms the scar tissue, often after blast exposure, most classically linked to the military setting.
Yeah.
it has a unique pattern. It's at these gray white matter junctions. And you see it in right near blood vessels and at structures lining the ventricles.
Okay.
So if we were going to say what it is, that's probably in part what it is.
And then do we know, okay, so a couple questions then. So the first one is, do we have any kind of data on how much of this, again, it takes, sort of like the 1,000 headers of the soccer ball, right? Like,
yeah, that's preliminary. The 1,000 is a preliminary.
I get it.
A couple of groups.
I get it. But like, do we have any preliminary data to this effect, right? Like certain number of blasts, proximity to blasts, anything like that, where we get a sense of how much it takes, so to speak?
I don't know that we have a blast threshold.
Okay.
People have tried to play that game with recordings. The recordings sometimes are inaccurate. And, the other problem with that is you may be, or I may be, more susceptible than Bobby or than Tommy, either genetically or otherwise. So we just don't know.
Mm-hmm. So that being the case, what about, actually, let's before we get to this, let me start with, what about, are there specific, I don't know if phenotype is the right term here, but is there a specific like way that this then presents itself in terms of the way guys act? Is it angry outbursts? Is it cognitive dysfunction, memory loss, any of those things? Is there specifics?
I think we just don't know, right? We just don't know yet. It's been proposed, right? We don't know, again, the linkage to the phenotype, to how people are, that it could be related to everything from irritability to mood swings, to sleep disorders, to concentration problems, to chronic headaches.
Okay.
But so are other things they experience.
Right. And
People
this is
with
the
a
challenge.
lot of chronic pain are often depressed.
Yeah. So what about...
They also have poor memory.
Yeah, right. What about recovering from it then? Like what's the hope right now of, can you work your way out of this? Can it heal? Are there things that you can do for yourself that way? Are there like pharmaceuticals potentially that come into play here that could help?
I think a number of pharmacotherapies or anti-tau or anti-astrogluteal therapies have been thought about, but I think they're way, way, way premature for humans.
Okay.
But what I would say is people have been exposed and they can't go backwards. What they can do is go forwards, right? So addressing every health aspect that they have control over can really make a difference. There's been a number of studies in people who have very strong Alzheimer's or other risk. They optimized their health. They optimized their sleep. They had pain control. They were treated and weren't depressed. They were active in new cognitive activities. Yep. They were socially engaged, and often our guys withdraw. And yes, they got into trouble over time, but much later than the group that didn't. So they pushed out that real health span, and that's okay. You can't go back, but if you can go forward and mitigate it and give yourself more quality over a longer period of time, that's meaningful. That's an aggressive outward approach.
What about getting upstream on it then in terms of mitigation and prevention? Like, are you working with, SOCOM or NSW or anything to kind of look at what we can do as guys? Because look, there's a job to do here, right? And we have to do the job. And there's just like it's a high risk job, right? And so there's some amount of risk we have to accept. But like what could potentially be done to sort of mitigate some of that?
Well, I think it's everything from blast training to procedures to when people don't, again, need to be overtly exposed, what can be done to mitigate those things, to various elements of how we train people to recoilless rifle fire exposure, that in some cases that training on Carl G's is just not necessary. And so how do we mitigate things down to unnecessary versus necessary? You got to do the job.
Of course.
The job's got to be done, right? No one would argue that. I don't know that some of the proximity, some of the training, and some of the rotational exposure effects are necessary. And so mitigating what we know now while we measure to do better over time.
Yeah. Yeah, I think I would happily trade back every single Carl G round I ever fired.
Yeah,
I do without
there's
those.
no one. I've seen them go on, but to be honest with you, I don't know anybody who thought those were big time fun.
No, not a lot of fun. What about psychedelics? What's your cut on those?
Yeah, so I think we're entering an era where, we had all of this era that they were the worst thing in the world.
Yeah,
So
that's what I grew up with. Yeah.
Right. We were all taught that. And frankly, any research on them was essentially banned.
Mm-hmm.
But we're now entering an era that in controlled scenarios, psilocybin and others may be helpful for PTSD or depression. But I want to be cautious in saying that. These are very controlled research scenarios, right? Not necessarily going to out of the country places or other situations. So these things that have some optimism in some ways rebooting the brain probably should be done in a very controlled, supervised scenario.
Sure.
Under either a research setting or under a setting where you have highly experienced, structured people, not necessarily just, I'm going to go here and get it done. And that's where we worry about the outcomes. When we have it, it's in a refined program that is beginning to explore these things, and this person meets this very specific criteria, then it could be a future option for sure. Mm-hmm. There is some promising data about that.
But yeah, is there any data that shows though, like some kind of brain reconstruction that happens? You know what I mean? Like a healing of the brain that happens with any of the substances?
More like rebooted wiring.
Yeah. No, I mean, look, I've done some of that. I know plenty of people that have done it, and I can speak to sort of that aspect of it, like sort of the experiential component of it, the potential. But I'm just curious if there's like a,
I'm not aware of anything that says it's taken out toxic protein.
Okay, yeah.
I am aware of studies that show enhanced network changes that people recover, and it has a relationship to either neuroimaging or neurophysiologic rebooting or relinkage or a more adaptive situation.
Let me ask you about the sort of the interface astroglial scarring, like blast stuff. Is that like, is it systemic? Is it like across the entire brain? Does it happen in a certain part of the brain?
Yeah, so as we said, astroglial scarring has its own sort of pattern that's been proposed. We have to be cautious because we need to know that the data is still limited. Mm-hmm. And it tends to occur at junctions between the gray and the white matter and various kinds of spaces like that. And that's the distinctive pattern that people believe exists with astroglial scarring.
But are those junctions like, in everywhere in your brain, or are those in specific parts of your brain?
Well, they tend to be in the following areas if we think about it. In glial areas of the periventricular regions, in areas where gray-white interfaces are distinct. Those are the kinds of places that we see it.
Okay. And the diagnostics of that, is that still something like CT?
That's also postmortem.
Postmortem. Okay. Yep. Is there any hope like of something coming on the horizon where you could do it in a living patient?
Well, I think that's going to be the whole thing about certain types of imaging.
Yeah.
Right?
Yeah.
Can we detect this in certain high-end imaging and be secure that it's linked to the pathology and not another covariate, as you were saying?
Yeah.
Right? And so it's that great white matter junction. It's the superficial lining of the cerebral cortex. It's areas near the brain ventricles. That's typically where we see this.
Okay. Got it. What
But
about
the linkage between that and the clinical syndrome, that's not a direct one-to-one yet.
Yeah. Got it. Now, what about, I mean, you always hear kind of these stories, and I've read about some of them, where it's someone can have a damaged portion of their brain and their brain essentially remaps whatever their capability, and that is real, right?
Totally. We see that in stroke people all the time. We see it with people with focal severe brain injury. I have patients who there is no one who would believe that on day 7 or day 5 after the injury that this person is would do well. I have a young person who's finishing graduate school. I have another person who's back to being a head of a bank.
Okay.
The brain does remarkable things.
Yeah. And I
just have to believe in that over time.
Yeah, and totally. And this is one of these things that like I wish more people would sort of believe, to your point, like buy into. It's like this organ of ours that's in the middle of our head has an incredible like a capability to remap and regenerate, not necessarily regenerate, but just figure things out, right? That's what it does. And like I just think, unlike some other injuries, it's like don't assume you're just screwed if you get some kind of diagnosis of TBI or whatever it may be, or even if you think
they're not necessarily, but the issue is what can you do to be proactive?
Mm-hmm.
Most of our cohort who are in the SEALs and our special forces members are people who've been activists their whole life.
Yes.
They've been proactive. That's how they got that far. And what my big point is, stay proactive.
Yeah.
It's what got you far. And being proactive with this, being proactive about recovery, being proactive about how you live your life, understanding that there's risk. Okay, what is known now that I can mitigate? And 5 years from now, when there's more, I'll add on.
Yeah. So with that proactivity, outside of what I would call kind of the basics, right? Like eat well, sleep, exercise, like these things that we know. What outside of that has shown the most promise in terms of either therapy or treatment or whatever from you?
Right. So first of all, eat well is not such a simple thing.
Yeah.
Right?
Well, it's easy. It's not simple.
Right. It's easy. It's not simple. But even knowing what to eat. So
It's simple. It's not easy. Sorry, I got that backwards. It's simple, not easy.
Yeah. No, you're spot on.
Yeah.
That basically says that what we eat very much affects our microbiome in our gut, and that there's a gut-brain axis that's really important. So inflammatory stuff is not very good. In fact, I would also argue that we have a paper that shows that excessive salt, at least in animals, produces an anxiety problem that's long-lasting. So those kinds of things are extremely problematic. But the other thing that we know is that aerobic exercise builds brains. It sounds boring, but aerobic exercise builds brain networks via a protein called brain-derived neurotrophic factor. And humans, in some ways, evolved uniquely with the capacity to sweat and run longer distances.
Yeah.
And it was linked to a reward structure, right? You're running, you find where the food is. I remember where the food is. And so there is a brain building capacity to aerobic activity that it's less convenient and less special, but it's among the most powerful.
Mm-hmm.
I think we're looking at various supplements and other things to say, which one of these could theoretically be effective? There was one that was approved in 59 countries. Was one of the leads behind this multi-center study. Man, we thought it was going to work. It worked in the lab. No, it didn't work.
Oh.
Not only didn't it work, there might have been a subgroup of people that it didn't help at all.
Okay.
So I think all of these things we need to understand how much and who and when.
Yeah.
So for example, if you could truly get enough fish oil into people, into their brain, and not do it in a toxic way and not make them sick and not make their blood too thin, could you potentially produce some good? Yes. Dosage, delivery, timing, in whom?
Mm-hmm. What are you working on right now? What's the future for you in terms of?
Wow. So we're doing a bunch of different things. One of the things we're trying to understand is just linking brain injury itself to a lot of comorbidities.
Mm-hmm.
So we have noticed that there's just head injury itself is a link to hypertension and heart disease
Sure.
through autonomic stress and dysfunction and inflammation. And it may have a linkage to cancer. And so we're trying to understand the biological mechanisms of that, and then how do we mitigate it? And then on the recovery element, we're trying to focus in on a few of these kinds of therapies that I described, either stimulatory or things that are supplementary that can enhance the ability of the brain to both recover and enhance that health span space.
Okay, cool. Any topics that we didn't hit on in this that
Oh, you're awesome. We got pretty broad, Chris.
I think about this stuff a lot. I mean, like I have my own kind of personal history, and obviously with stuff we do at the foundation is very tied into this. I've seen you talk numerous times at the Impact Forum. So I just think it's really, I mean, obviously it's really relevant, but it's also something that I think you highlighted that, hey, like, you know, there's a lot of unknowns here, and don't go down this sort of doom spiral of, oh my God, you're screwed if you did X, Y, Z. I just don't think that that's true at all. And we certainly can't buy into that. That's not helping, right?
Yeah, I think this doom spiral leads to something I refer to as a nocibic effect.
Yes.
I tell people,
Yep.
you know, y'all, a good portion of you are going to get a bad headache, and you better, right? What do you think happens if I get a group worrying about that? And there's a real biologic mechanism to it.
Yep.
So I think we can't just blow it off. Don't ever worry about it's garbage. No, that's not true to tell people. The other side is you're doomed probably creates a fatalistic aspect.
Yeah, for sure. Yeah, absolutely. The other thing I just love that you said is the whole thing about exercise. It's just, you know, the fact that exercise is kind of like not the magic pill, but it's about as close to it as we can get out there. Like it's so beneficial. Like if you do nothing else, exercise, like it's so good.
Yeah.
For you.
And I think we don't do it well enough at all in our country. And I think there's a simple reason why, right? It's always tomorrow. It takes time. We as Americans are wonderful people. We lead the world in a lot of things. I'm not convinced we lead the world in taking care of ourselves with time.
Yeah, I would agree.
And if you were going to say, hey, put an investment into your employees and everybody, well, man, right? If we had people eating a little bit better and running, I'm going to guess, now would be super controversial, but we'd hit up 20%, maybe 30, maybe more of the chronic disease burden.
Yeah,
we'd pull a big hit on it.
I'm completely with you on that. So it's good to hear you say that, because like I think, you know, it's important for guys like you that are clinical and have all this background and knowledge in these arenas to be saying that, because I totally agree with you on that. So
Chris, thank you for what you do.
Oh, of course.
Truly.
Yeah. Well, thanks for supporting us and being with us and educating
people. You guys are awesome. It is among my favorite tasks to help this group, because what you do is so meaningful to our country and to so many people. So thank you.
Thanks for listening to On the X, the official podcast of the Navy SEAL Foundation and an IRONCLAD original series sponsored by Mechanix. Learn more at NavySealFoundation.org or text On the X to 60104. See you next time.